no need to show you. Thank you. There's no need to show you where the exits are. So the alcohol occasionals showcase new and innovative research on alcohol. They are free online events and they provide the chance for researchers, healthcare professionals, policymakers, members of the public, and also those with lived experience to hear about alcohol-related topics and discuss and debate the implications for policy and practice. We have a full series and schedule. The link should be in the chat, so please register below to be a member of both and to take part in further events. The Scottish Alcohol Research Network is a network of researchers, academics, third sector partners who came together about 12 years ago with an interest in alcohol public health policy in Scotland. And we hope to share knowledge and skills, facilitate discussion, build connections between researchers, and really gain that, build that capacity within Scotland. If you're not a member and you would like to find out more, to join, please contact us. And just a little bit more about SHAP, the Scottish Health Action on Alcohol Problems, our wonderful partners. They are a partnership of the Medical Royal Colleges and the Faculty of Public Health in Scotland, and based at the Royal College of Physicians in Edinburgh on Queen Street in a beautiful location. Using the best available evidence, SHAP provides the authoritative clinical voice on how policymakers and clinicians can reduce alcohol-related harms in Scotland. So that's my little plug and marketing pitch done. And swiftly over to Christopher. You've heard that he's in his final year of his PhD. And the seminar today, as you can see on the screen, Optimising Relapse Prevention for Patients with Alcohol-Related Cirrhosis. This is a national survey he's going to share with us. And we were just speaking before the conversation started openly here. And I think Scotland have had some input into some of these findings. So results, so it'll be really great to hear. The seminar itself will focus on the research which explored the barriers and facilitators of abstinence for patients admitted to hospital with advanced alcohol-related liver disease through an online survey of experts and stakeholders involved in the care of patients with alcohol-related liver disease. So we want to stimulate lots of questions, debate, and Christopher is here today, so it's wonderful. Please remember to put any questions or reflections in the chat box, and we will get to as many of them as soon as possible after the presentation. So it's with great joy that we hand over to Christopher. Christopher, thank you so much for taking the time today, and we are delighted to have you here as our guest. And we have a huge audience. Wonderful. 66 so far and more joining, 67. So yeah, you've got a very, I guess, mixed and wide audience that is growing as we speak, but I'm going to hand over to you, share your slides, and let's hear your excellent presentation. Thank you so much again.
Thanks. Yeah, thanks for that really kind introduction. It's a real pleasure to be able to speak to this group. I've certainly, been to a few alcohol occasionals before and asked some questions, and it's always very interesting. So it's great to be able to present this work. And as you say, I'm sure many people on this call will have actually contributed to this work, and without their help and collaboration, it wouldn't happen. So really grateful for that as well. And this is the first time this data is being presented, actually. So that's also quite exciting to see what people think about it. But yeah, I'm a PhD fellow at the University of Cambridge. I grew up in Glasgow and did my undergraduate medical training at the University of Edinburgh. But my wife is from Suffolk, and she was quite right when she said the weather down here was a bit better. So we've kind of stuck it out down here in southeast England. But yeah, this PhD came about because of my work as a hepatology registrar, working on the wards, and 80% of admissions with decompensated liver disease were alcohol related. And the real sad thing is what you would see is these patients would get better having been very, very sick, and then sadly return to alcohol and return to the hospital, often within weeks or months, and that often didn't end very well, often for quite young people. And so when I had the chance to do some research, one of my colleagues, there's always sort of projects banding around, and sometimes you just try to latch onto something that other people are doing. But one of my colleagues sort of said, well, what are you interested in and what do you want to do? And this is what I was interested in. And so I was really lucky to get this group of supervisors together. So Mike Allison's a consultant down here in Cambridge. Graham Martin is a professor of healthcare improvement at this institute, and then Caitlin Notley is a addiction researcher at University of East Anglia. So we've got this sort of multidisciplinary team, and uh, and as I say, I was really grateful to be funded by the NIHR. No conflicts of interest apart from that. And no presentation about alcohol-related liver disease would be complete without this slide, famous slide, which shows that for every other cause of death over the last 40 years, we've been getting better at treating it. That the mortality has gone down, except for liver disease, which has gone up by 400%. And that is, absolutely scandalous, really, and a big kind of call for action. And when we combine that with what we know about what's happened since the COVID pandemic with alcohol-specific deaths, where, basically every year from 2021 onwards, we've hit new all-time highs in alcohol-specific deaths. And there's lots of, reasons for that, which we could go into, but, this is a massive problem, basically. And of course, alcohol-related liver disease is a spectrum of illness. It goes from having fatty infiltration of the liver that then becomes inflamed and the liver gets scarred. And then ultimately you can get sort of irreversible scarring called alcohol-related cirrhosis. And in the middle of that, there is this more acute condition used to be called alcoholic hepatitis. You see this paper is from 2018. We now try to avoid that terminology, and instead we use alcohol-associated hepatitis. And that can occur in people even who don't have cirrhosis, and is associated with very high mortality. And my research is focused on this end of the spectrum, these people with severe illness. Of course, there's lots we can and should be doing to stop people getting to that point, but my research is focused on this end of the spectrum. And as I say, that's partly because these are the people who come to hospital, these are the people who die, but also because even at this really advanced stage of liver disease, there's this absolutely fantastic treatment, and that treatment is to be abstinent from alcohol. So even for people with severe alcohol-associated hepatitis, this is just one example of many studies which shows the same sort of thing. You can see here that 2 months after being in hospital, the people who were able to stay off alcohol, 80% of them were alive, whereas the ones that returned to alcohol, 80% of them were dead within 2 months. So it's this incredibly powerful treatment. And yet, we know, as I say, that not only is relapse to alcohol very common, but also engagement with relapse prevention therapies and treatment is poor. And that, yeah, as I say, is essentially the problem that my thesis was looking at. We've recently been able to show that the relapse rate to alcohol in patients, so people, we looked at people in our region, 200 people who had been admitted to hospital with decompensated cirrhosis, so really sick, nearly dead, and within 3 months, 2/3 of the people had gone back to drinking alcohol. And then this 1% figure comes from a big cohort study done in the US, looking at people with cirrhosis, where they looked at about 20,000 people and showed that only 1% had received both talking therapy or psychological therapy and a medication for alcohol use disorder. And this is this data I was just talking about. So there's 200 people in 10 hospitals in East Anglia. And apart from the fact that, a lot of them relapsed to alcohol, you can see that at 3 months, the death rate was about 24%, and that most of the patients were not eligible for life-saving liver transplantation because they had returned to alcohol or they had died or we'd lost them to follow up. but the obvious criticism is, well, why do you need to do what? First of all, why is a hepatologist doing this work? Why a liver disease specialist? This is about relapse and about alcohol use disorder, and which is psychiatric diagnosis. Why are you doing this work? And also, why is it important to look at this problem specifically in these people with advanced liver disease? Surely all the things we know about alcohol use disorder and relapse prevention could just be applied to this population. Well, a few reasons I think that we should be interested. One is that your relapse prevention treatment, your treatment that helps somebody remain abstinent, while it may not be cost or if it may not be cost effective or it may not impact people's health outcomes in people without liver disease, if you target this population with severe advanced liver disease, you might see those benefits that would make the treatment more fundable and more attractive. And also linked to that, we can evaluate the impact of these treatments based on clinically important endpoints like hospitalization, mortality, change in liver disease scores, etc. There are some specific challenges in patients with cirrhosis. Particularly, the obvious one is around drug treatments for alcohol use disorder. And just to summarize that, these are some of the sort of commonly prescribed drug treatments for alcohol use disorder. So you see disulfiram or Antabuse, acamprosate, and naltrexone, which hopefully people are familiar with or know about some of these. And essentially, the only one that's actually been tested in patients with advanced liver disease is baclofen. We think that acamprosate and naltrexone are probably safe, but we don't know that. And disulfiram definitely is not safe in patients with advanced liver disease. And so there's a bit of reluctance among prescribers of these medications as soon as they see someone's ALT being a bit elevated or something. There might be interventions that would be actually specific to this group. So both in terms of making sure people understand the risks of returning to alcohol, the impact that has on their liver disease, their stage of liver disease, all of that would be specific. And then things like biofeedback. So looking at people's blood results, demonstrating them that their blood results are getting better, maybe their liver stiffness is getting better, all of that trying to provide some kind of positive reinforcement to help them remain abstinent from alcohol. And then finally, we see the patients. So patients usually come to the liver clinic, although we do have, not insignificant DNA rate, but it's certainly much better than the attendance at community alcohol services, for example. So they come to the clinic. It's an opportunity. We see them in the hospital and in the clinic. We can be doing something at that time. And obviously, when they're in the hospital, they're abstinent from alcohol. So if people who are physically dependent on alcohol have gone through a detox, they're actually off it by the time they leave the hospital. And so this is a great opportunity. And then part of what the research has looked at is whether this group of people is different in any other way. Are they particularly refractory in terms of that they're more likely to relapse to alcohol, or are there any other sort of unique aspects to these patients that we need to consider? So I'll just quickly whip through the first couple of studies in the PhD because they kind of lead to this final study. The first was this systematic review. So, if you're going to think about helping people reduce alcohol intake, you got to say, well, has this been done before? Has anybody found something that already works and that's got a good evidence base? And we found 23 studies looking at this question, which, is not a lot, and only 6 randomized trials, 4 of which were feasibility studies. So you've got this great treatment, this massive need, and we got 2 randomized trials looking at trying to sort the problem out, and then quite a lot of kind of database cohort studies, and that looked at a wide range of different interventions. So drug treatments, talking therapies, educational interventions, even fecal transplant to reduce alcohol craving. And these studies looked at a mixture of kind of what I've called alcohol outcomes, so whether they reduce drinking or not, and clinical outcomes, so hospitalization, death, and so on. And so really only one randomized trial, as I said before, showed a benefit on our primary endpoints, which were abstinence, mortality, and hospitalization. And that was baclofen, where there was an odds ratio benefit of 6. And that's an old randomized trial. And the reasons that we're not actually using baclofen in this patient cohort now are not particularly clear, but essentially there's a concern about encephalopathy, so drowsiness, and the concern around the dosing. And there's actually a study going on at the minute in the UK to try and answer that question about dosing and get some more evidence for baclofen. But it is widely prescribed in France and elsewhere, and in some centres in the UK. And then when we looked at the sort of the rest of the data, so the non-randomized studies, the ones that did some kind of accounting for confounders, so we call multivariate analysis, where they try and take account of things that might muddle up the data. Most of them, as you can see, point to benefits of doing something at least in patients with liver disease, both in terms of returning to alcohol, being readmitted to hospital, and even mortality. So there's signs there that actually, if we do something, we can affect people's outcomes. We tried to do a bit of meta-analysis of these studies, and as you can see, there was a trend towards, on the top there, increased rates of relapse, increased rates of abstinence, and on the bottom, decreased mortality. So an overall trend, but not actually statistically significant. So this is one of the other studies in the PhD where we tried to answer that question about, what is different about this population? What makes it hard for these people to remain abstinent from alcohol? And I'm not a very sort of complicated person in terms of the way I think about research. So to me, the obvious thing was, well, let's just ask these people, what makes it difficult, and why do you go back to drinking, and so on. But let's ask the people that we need to know about, the ones that are in the hospital, sick, the ones that might not come to your clinic and do your research study, or might not answer an advert on social media or email. Let's just grab them while they're in the hospital and speak to them. So this was the study essentially. It was people in the hospital at 2 hospitals in East Anglia, semi-structured interview, and we used what's called a constructivist grounded theory approach. So we're trying to build a theory or an understanding about what's going on from the data or the information that we're getting from the patients, rather than going in with a preconceived idea or a preconceived structure and then testing that in the interviews. So there's 2 different ways of doing qualitative research, which have their strengths and weaknesses. But I thought one of the strengths of this approach was to go in kind of agnostic and just say, let's see what we hear from people. And also, it allows us to be quite selective in what we do with the interviews. If you're doing interviews and it turns out that all the people you interview are kind of the same, then you can just stop interviewing them and interview other people with different views and try to build a bigger picture of your theory. So we got 33 people. You can see that the sort of age and gender distribution somewhat represents what we see in alcohol-related liver disease, mostly men and people in the kind of 50s. But we did get quite a broad range. You can also see that these were people who'd been in the hospital before, tended to have had previous admissions, and about half of them, it was their first admission with liver disease. And most of them were drinking at the time they were admitted to hospital. Although we also felt it was important to kind of learn from people who had been able to achieve abstinence. We didn't get a lot of ethnic diversity, which unfortunately we just don't have in this region as much as we might elsewhere. And similarly, the distribution of deprivation, doesn't match what we see in alcohol-related liver disease nationally, and maybe that reflects. It definitely partly reflects the geography down here, but it also probably reflects the people that were willing to be interviewed. So still some weaknesses there in terms of getting talk to the right people. But what did they tell us? Well, there was sort of 3 key themes I want to cover. One was about motivation, and that is to say that these people knew what the stakes were. They understood that they were really sick, that they'd been in the ICU or yellow or whatever in the hospital, and that if they went back to drinking, that might be it. That if they relapsed to alcohol, the stakes were life and death. And they got that picture. But as a result, they felt really confident that they could do it, that fear or that kind of black and whiteness of the situation would be enough. Well, obviously, I'm not going to go back to drinking because I'm not going to end up like this in this situation again. And so you get this kind of sense of confidence. Um, and that's coupled with the belief that really it's all down to them, that it's all about willpower and all about determination. And as long as I'm determined enough, then I'll be able to do it. And because I'm in this black and white situation, well, obviously I'll have to do it. And so those two things, if you combine those two ideas, you have a situation where when you say to somebody, well, we'd like you to go to community alcohol services, or have you thought about Alcoholics Anonymous, or would you take this medication? They say, well, like I don't need the medication. I don't need it. I don't want to go to community alcohol services. I've got it. Like I get the idea. I don't need I'm not going to drink anymore. And even if I did want to do this thing, it doesn't matter because it's all about willpower and determination. Um, and then the final theme I want to highlight is this thing around the sort of alcoholic identity, or this idea of and the stigma associated with that. Because what we found was that although everybody we interviewed certainly had advanced liver disease, I mean, there's all people with cirrhosis or alcohol-associated hepatitis. Most of them, not all, I should say, there are certainly people who were pretty reflective about their alcohol problems and self-identified as alcoholics. But many of them did not. And you would hear things like, I'm not a bad drinker, or I never let it affect my work, or I would never drink and drive, or words to that effect. And we call that process othering, where although they've got a diagnosis of alcohol-related liver disease, they don't want to adopt this alcoholic identity. They want to maintain the idea that they were always in control of their drinking, and that therefore they'll be in control of whether they go back to alcohol. And so for someone like that to go to community alcohol services is kind of admitting defeat. It's saying, well, I must have a problem, or I must have had a problem. And also, it means that you are inviting all of that stigma and that negative energy that you've just projected on these other alcoholics, these bad drinkers. That you are opening the door up for other people to look at you and say, well, you must have been an alcoholic. And and I think that probably, although this isn't, haven't sort of researched this, probably in public discourse, having alcohol-related cirrhosis is people do probably just equate that to being an alcoholic, and we could see that people were pretty defensive about that. So when you combine those three things, you have it all pointing in the same direction, which is to say that people, feel that they don't need relapse prevention. And sadly, that's the most common thing we see when you look through the notes. Usually people are offered something and usually they decline it. So having spoken to the patients, this is the bit that you sort of signed up to hear about. We then wanted to speak to the other stakeholders in this system and see if you got the same sort of ideas, but also to understand the system more broadly and the challenges in it. And we did all of this remotely, so anybody could take part who self-identified as a stakeholder. And I spent a lot of time sending around emails and trying to get people to do this thing. And this is the overall sort of structure of the study. So the first bit was sending lots of emails and social media posts and talking at conferences and trying to get people to do the thing. And then we got the survey responses. And then we took the survey responses and kind of analyzed them thematically, grouped things together, got rid of ideas that were duplicates. We had a meeting with our patient group, which is 6 people with lived experience of alcohol-related liver disease and alcohol use disorder, initially to go through the responses and how we had taken them and turned them into a list of recommendations. And then we had another meeting with a steering group of experts, which included 4 people with lived experience as well. So the idea was to take all of what we got from the survey and some of the other things we'd learned over the course of the research and from other bits of evidence, and then generate a list of recommendations about how the system could be better, and send that back to the stakeholders. And so these are the stakeholders that we recruited, and as you can see, quite a good cluster up in central Scotland, but generally quite a good spread across the UK. Probably a few more down here, as you might expect from the way it was distributed and so on. But actually, is a kind of national stakeholder. So And then in terms of participants, we overall had 188 unique people participate in the study. You can see, the numbers vary a bit across the different parts of the study and across the different stakeholder groups. We would certainly have liked to get more family members and carers, and we certainly would have liked to get more commissioners. But unfortunately, we struggled to recruit in those areas. But we got lots of people who were hepatologists, lots of people with expertise in alcohol use disorder, and quite a few community-based practitioners, and then a total of 33 if you put the patients and carers in the same sort of bucket. So overall, some good recruitment. And actually, if you look at other sort of consensus building exercises, I don't know, there was one recently looking at research priorities in alcohol use disorder and alcohol-related liver disease, which I think was 27 or 30 people represented. Another big paper from the US looking at how to run clinical trials in this population. And again, I think they had sort of 25 or 30 people. So this remote online methodology, did seem to allow us to recruit quite a lot of people, which is great. Okay, so what did they say? So we asked 3 questions, tried to keep it really straightforward, and it was all open-ended. So just here's a question, you tell us, what the answer is. No multiple choice or anything like that. And we asked the stakeholders to imagine a person with alcohol-related cirrhosis who's coming out of the hospital where, abstinence is literally life or death. And, what is the challenges that this person faces in terms of avoiding return to alcohol? So certainly, it was definitely recognized that the alcohol use disorder is a substance disorder, that it can be an addiction, that people are dependent physiologically and psychologically. And that even if we don't call it, drug dependence, it's certainly habitual, that people have been drinking often usually for years and years in the same pattern. And that just because you get admitted to the hospital, that doesn't all go away. And so those same cravings, same triggers, same patterns are going to be present when they leave the hospital. And that's just intrinsically difficult to overcome. There was certainly a lot of feedback about the use of medication. So, as I said before, things like ecaprase, baclofen, which reduce craving, and a strong feeling that these medications were being underused, or in fact not used at all. Another big area, which is certainly very challenging to address, is that the underlying problems or underlying difficulties that have led someone to drink to excess have not been addressed by the fact you come into hospital. So the fact that you have financial struggles, that you have anxiety, that you're in a social circle that's drinking, that you have mental health problems, history of trauma, all of that we know makes it contributes to people turning to alcohol for help is not addressed by being in hospital. And there's nothing that healthcare professionals really do to address those challenges. And so if you just send somebody back out into exactly the same environment that they were in before they came to hospital, it's very likely that you're going to end up with the same result. There's certainly a feeling that some patients didn't understand the severity either of their liver disease or their alcohol use disorder. A lot about the services themselves, underfunding, lack of trained staff, lack of appointments, concerns about the services being linked to drug services. So that whole thing about stigma associated with reaching help, that was kind of made worse if when you go to the community alcohol service, it's actually the community drug and alcohol service. And certainly we heard from patients in the interviews who didn't want to sit next to intravenous drug users and so on. And then, another sort of chunk around multidisciplinary working. So poor transition from the hospital into the community. So, the hepatologists don't know what's going on in community alcohol services. We don't know what's going on in mental health services, and they don't know what we're doing. And these things are all in kind of their own silos, both in terms of the information, the handover. And so, those systems don't integrate well together. And certainly, also some aspects about the sort of process of discharge where patients were either expected to self-refer to alcohol services rather than kind of having a direct link in, that they didn't know who to contact when they left the hospital. And then sometimes the people were discharged without actually having completed a physiological detox. And then kind of outside the scope of this research was just the wider role that alcohol plays in our society and how that creates pressure for people. Okay, what about access? What stops people getting any help or going to community alcohol services? Well, a lot of very practical stuff. They can't get there. There's no transport in where they live. They can't afford the transport to get there. They can't afford to take time off their work to participate in this stuff. They don't know what the services are or what time they are or where they are. They need to self-refer, as I mentioned. And then probably more specific to patients with liver disease, the actual aspect of their physical health. These are often patients who may have physical challenges like a frailty, sarcopenia, so muscle wasting, maybe even, still having ascites, fluid in the tummy or around the legs. But also, cognitive challenges. So encephalopathy, which is a confusion caused by liver disease, or alcohol-related brain damage, or perhaps they've had seizures or an element of Wernicke's encephalopathy. So all these things, make it difficult for someone like this to engage in relapse prevention. And then stakeholders also talked about motivation, but they felt motivation could be low for a number of reasons. One about problem recognition, which does tie into what we heard in the interview. So people don't think they've got a problem and therefore they don't need help. But also that some patients with advanced liver disease might feel that their disease is so advanced that it's beyond help, that it doesn't matter. They may not actually understand the data I showed earlier about how good the outcomes can be for people who stop drinking. And I often say to patients in the clinic that a lot of people in my clinic are very, very stable. You just phone them every 6 months and they're completely fine. And these are the people who stop drinking and their liver recovered and did very well, worked well in the long run. And then there may be people who simply don't want to change, don't want to stop drinking. And then yes, a lot around stigma, shame, not wanting to engage with services because it invites all of those negative connotations that we've discussed. And so we also then asked the stakeholders for examples of things that do work well. A lot of it's kind of the opposite of what you've just heard. So an empathetic approach, showing compassion, trying to destigmatize these things, having trained and experienced staff members. I think we know that, the way that community alcohol services are funded and so on, they are not always able to recruit people that have got a lot of training or experience. Pharmacotherapy, so using these medications that we talked about, multidisciplinary working, so basically all the opposite of what we just said. And there were some great examples. I know that, in Glasgow, for example, there is an integrated clinic where people see the hepatologist and community alcohol services at the same time in the same site. And so we heard a lot of, and also things like assertive outreach was cited again and again as a really good example, a good model of care. And so there were these good elements of practice, but it's just not being systemically applied. And when I've spoken to people at conferences and so on about their great service, the obvious question is, well, how did you get it funded? And, how long? And often it's sort of, well, we cobbled together some funding from this place and we managed to get a staff member and then, we're not sure how long we'll be able to sort of keep it going. And that's a real shame, I think. That was a steering group. And so we took all of the answers from the survey and then generated initially 75 recommendations, quite a lot, quite a lot of problems, quite a lot of recommendations to improve it. And then we weaned that down to a slightly more manageable 48. And so then those 48 recommendations went back to the stakeholders. Went back to the stakeholders for a rating system. So you had to rate it as either agree, strongly agreed, strongly disagree, etc., etc. The ones that got 70% or more agreement got through to the next round, which was most of them. So 38 out of 47. Now that's quite common in these kind of exercises, but it also tells us that we were, hopefully sort of hitting the right notes. I mean, most of the people who submitted the problems thought that the recommendations would address those problems or thought that the recommendations were important. The question I should add was, this recommendation should be prioritized. That's what we asked, and they thought 38 out of 47 of them should be prioritized. So yeah, it suggests a few problems in the system. Interestingly, the ones that were rejected, uh, inpatient rehabilitation, some of the recommendations were around, well, this person with cirrhosis, maybe we should prioritize them. Maybe we should like fast track them. Okay, maybe we can't see everybody with alcohol problems, but could we just see these people? And actually, the stakeholders didn't think that was a great idea. They felt that was somewhat biased and kind of unfair to other patient groups who also need help. Um, but even things like, offering transport or financial support, a lot of this was rejected. And when you look at the comments, it's clear that stakeholders felt that some of this stuff was a bit utopian. That it was that it's a sort of great idea, but it'll never happen type of thing. Um, and so that's why we were keen to sort of refine this down to stuff that maybe could happen. And so rather than ask people to have another round of consensus voting, which didn't seem useful, we pivoted to a ranking system, and we asked people to rank their top five of the recommendations that were left. So the top five of the 38 that reached consensus. Now, this is the sort of slide you're supposed to never show in a slideshow because it's too small and it's too much data and nobody can understand it. But especially if you happen to be colorblind like me, but I can tell the difference between red and blue at least. This is essentially the results of the ranking process. So the way we did it was if somebody ranked it something number one, it got 7. We asked them for top 7. So if they ranked it number one, it got 7 points. If they ranked it number 2, it got 6 points, and so on. So you got more points if the thing was higher ranked. And on the far left, you've got the overall ranking results for each recommendation, with dark red being the highest ranked or the most points, and then down to dark blue being the lowest points and lowest rank. And then across the board, you've got the each of the stakeholder groups. And this figure kind of gives you a chance to see where there was agreement and maybe where there wasn't agreement across the stakeholder groups. And because there was more hepatologists, they influence the overall points in the most. But actually, if we look at the patient group, which is obviously very important, 4 of the top 5 priorities for patients were also in the top 5 overall. And then we've done a bit of other analysis where we've accounted for the fact that there were different numbers in each group. And actually, the overall rankings don't change very much. There's actually only one change in the top 5 if you give equal weighting to each group. So the top 5 things were as follows. Number 1 overall was relapse prevention work should be presented as a routine part of care for patients with cirrhosis. Patients should therefore be required to opt out rather than opt in to relapse prevention. So I'm really excited by this because it's an idea that's been floating around over the course of doing the PhD, where if I say to patients, you need to take a diuretic or a blood pressure drug, or you need to come to clinic and get an ultrasound scan, most people don't argue with you too much. They don't say, no, I don't need that. But if you say to patients, oh, I'd like you to take a drug for alcohol craving, then they say they don't need it. And so I think we need to really change the perception around these kind of things to make it part of the routine care so that actually everybody is participating. And what that might do is it might mean that when we ask you to do some relapse prevention work, we're not saying you've got a problem with alcohol. We're not labeling you in any way. We're just saying that you have liver disease. That is undeniable. You have liver disease. And this is a thing that can help your liver disease in the long run. And we ask everybody who's got liver disease to do it. And so that might help sort of take away some of the stigma around that. It might improve engagement with it. I'm not 100% sure how that will look in application. It might be one of these multidisciplinary clinics where, you're coming to the liver clinic, but you're also getting this other thing tied in with it, and it's more about you having liver disease than having an alcohol problem. Linked to that is medication. So we knew that would come up high probably, that people should be at least offered these medications for alcohol use disorder. Certainly, I know in other clinics around the world and other groups that it's very routine to prescribe medication. Not saying medication's a sort of golden ticket, but certainly it should be part of the package. Then stakeholders felt that it was really important that people had clear information about, the risks of future alcohol and also therefore the benefits of abstinence. There was a feeling that people should be seen promptly, so within 2 weeks of discharge. And again, I'm sure there's likely to be challenges around actually implementing that, but highlighting the importance of this transition from the hospital, picking people up when they're in the community and making sure that they're getting support, and we're sort of keeping an eye on them and touching base. And then also tied to that, that people should be directly referred. So, I should be able to book an appointment for someone with community alcohol services rather than we give them the website or the email address, which is pretty much what happens now in a lot of centres. So that, is pointing us towards a set of kind of guiding principles around what a change to the service or an intervention might look like. It should be perceived as standard of care, as routine. There should be some control from the hospital team in terms of preparing. That it should involve information and education. That it should involve early review, prompt review, and that it should involve medication for alcohol use disorder. And that probably, although the term sort of alcoholic and that self-identifying as having an alcohol problem is a really important part of the recovery journey for many people. Obviously, one thinks of Alcoholics Anonymous, where although you don't have to, the Alcoholics Anonymous is open to anyone who's trying to reduce their drinking. But of course, the first tenet is to accept that you have a problem with alcohol, and that unfortunately puts a lot of people off. Although, of course, AA is, the most successful sort of evidence-based intervention, and it's also free and so on. So I think people should be directed towards things like AA, but for many others, we should probably try to avoid these terms and contextualize their problem with alcohol in a way that they can relate to and is not going to put them off and stigmatize them. So this is kind of what we're working on, is something. This has got a logic model where you try to put all these factors in and see what your outcome, what your intervention might look like, and what activities might be involved in it, and what your kind of outputs would be. But that's all further down the line, I think. And then these are just some unanswered stuff that I'm interested in, and in case there's more fodder needed for discussion. I'm really interested in this thing about problem recognition and a kind of identification of someone with an alcohol problem, whether this is something that we should be really tackling head on and getting people to embrace the idea that they had or have a problem with alcohol, or whether we can kind of bypass it in some of the ways I've discussed by making relapse prevention routine standard of care, by incorporating it with their liver disease and so on. I think there's going to be a really interesting role for alcohol testing, which is an intervention on its own. And that's been a big change over the course of my thesis, is the advent and availability of more and different tests for alcohol. I think we really need to think about how we maintain and support patients with advanced liver disease who, when they leave the hospital, are really motivated. They understand they need to be abstinent, but we know that because of the challenges they face in their lives, that motivation is likely to wane and reduce when they leave the hospital. And so how do we actually support that and maintain it and continue to give positive reinforcement? And then again, not really covered so far in this talk, but did come up in both the survey and the interviews, is about the role of no and low alcohol products, which I think is a total kind of dark area. in this population. People with cirrhosis and liver disease in my clinic are using these products a lot, and um, for a lot of them find them very helpful. And it is quite difficult to toe the party line by saying that they shouldn't be drinking these things because they have small amounts of alcohol and may lead to relapse, when patients are quite proud of having given up full strength alcohol. So I think there's that's an area, another area that I'm interested in. And then just to say thank you to everyone who participated, and people for all the different studies, and of course all the people on this call who no doubt contributed data. So that's me. I'll leave this one up maybe. And then, yeah, happy to take questions or provide further information as people like.
Wonderful, wonderful. Golly, I don't know about everyone else, but I've got so many questions. I'm gonna have to restrain myself.
There's a lot of
Okay.
information there.
Well, thank you so much, everyone, for your presence here, listening to this fascinating study. We have got one question in the chat already. So, Hannah, thank you so much. I'm wondering, Hannah, would you mind actually sharing that yourself with us, if that's possible? If not, I can read it out. But I really quite like when our audience are getting engaged directly. So, Hannah, I don't know if you're there. If you can just unmute yourself, and I can't quite see. Oh, I can see Hannah. I can see you're still with us. Hannah, can you hear me? Are you able to? Oh, okay. Oh, struggling to. Okay, well, oh, yes, maybe. Yep. Are you able to chat to us? Otherwise, I'll read it out, Hannah. Okay, I'm gonna take over. Sorry, Hannah, great question. So, Christopher, Hannah's question to you is there any evidence to show baclofen has a direct link between baclofen and encephalopathy drowsiness, and if presenting with these symptoms, likely related to disease rather than the baclofen? And how would we manage this in clinic? Would you hold baclofen reduced dose? So there's quite a few things in there.
Yeah,
Um,
so I guess Baclofen is uh, not licensed for this population. Obviously, if you're using it, it's off license, off label, but then so are the other treatments. So just be mindful of that. Um, and yeah, if you're using it in someone who has decompensated liver disease, you're right. There's a risk that they become encephalopathic for lots of other reasons, and you should be mindful of other triggers for encephalopathy, so infection, bleeding, constipation, etc., etc. Yeah, the, the evidence around baclofen in liver disease, as I say, one randomized controlled trial which had a positive result and didn't have a lot of problems with drowsiness. But drowsiness has been seen in other populations with baclofen, and so then when you combine that with liver disease, people get a bit concerned about it. And the drug of choice more so in the UK, it seems to have been acamprosate, which has less problems in that regard, although it doesn't have randomized trial evidence. So I'm not prescribing baclofen to anyone at the minute, but then I'm also trying to enroll them in a clinical study for that. So that's why I'm not using it in clinical practice. But if you are, that's great. And I think you'd have to start with a low dose as they have in the study. And yeah, I think if they become drowsy or sleepy, I'd probably stop.
Brilliant, lovely. And just to say, Hannah is a hepatology pharmacist at St George's Hospital in London, Christopher. So thank you, Hannah. I know it was difficult for you to join in there. We've had another couple of comments in the chat about thank you for tackling this problem in such an assertive way. Excellent presentation. Hannah has said thank you herself. So while I'm waiting on a few more questions, oh, here we go. Great. Jen, is it alcohol free or can they drink the low alcohol drinks?
So, as I think I suggested, nobody knows the answer to this. Most no and low alcohol products have some alcohol in them, and there is evidence that if you drink enough of these things, that you can, for example, test positive for alcohol on urinary alcohol test. Whether the amount of alcohol in it's certainly in, so low is less than 1.2%, no is less than 0.5%. So whether a drink that has less than 0.5%, how much of that you would need to consume to do damage to your liver, even a liver that is cirrhotic, nobody knows the answer to that. But anecdotally, there's lots of people with compensated cirrhosis who use these products and don't have any problems. The danger has been that they've been associated with increased craving for alcohol, certainly among harmful drinkers, and so that by using these products, you've not really given up alcohol, and so you're actually at risk of relapsing into harmful drinking again. And I think that's a very real concern. Certainly, that's the feeling of the sort of psychiatry and alcohol use community. Um, and certainly, if you're on the liver transplant risk, for example, you're not allowed to use these products at all. Um, but as I say, my personal feeling is that I think we could be a bit more liberal about these things. And I certainly don't chastise my patients in clinic who've got compensated disease, so their liver is working. They may have cirrhosis, but the liver is working, who are using these things at low levels. Does
Great.
that answer the question?
Yeah, I mean, I think Christopher, you've identified that this is this area, and we've those of us who work in the field have had a number over the many years. There have been a number of areas that have, been contentious for us, and it is that balance, isn't it, professionally and clinically around with the evidence base of trying to find that best way. And really, I guess the focus is on how are we able to best respond. I mean,
I think the
someone,
yeah, I think the big thing that's changed obviously is that these products have become much more
yes,
widely available and better. That they taste better and they taste more like what people are used to, and
yes.
so people are much more willing to use.
We did a session, I think it's probably, I can't even remember if it was this year, but last year, certainly on no drinks. We've got some colleagues up here in Scotland who are doing work around that. So I think it is an area that we'll see a lot more work being done, but probably not as much as we would like to. Okay, so I'm just going to go and we've got a
There's
few
another hand
questions.
up,
And I
Alistair.
Yes, I've got somebody just before Alistair. Is that
Right.
okay?
Yeah, yeah.
Because I'm trying to do it in order. So, Alistair, I know you want to ask a couple of questions. So, and I apologise if I'm not saying the name correctly. Chinedu. Just wondering if you have any advice on the best prescribing option for binge drinking. That was a question there. And a comment from Richard Gray saying you appear to dismiss disulfiram as unsafe. There are risks, but drinking has more risks. That's more a
That's my kind
comment.
of question. That's my kind of question.
Oh,
Um, so
go for
so
it.
prescribing for binge drinking. So one of the problems with all of the medications that we've talked about as being options for patients with liver disease, i.e., ecamprosate, naltrexone, and baclofen, are to prevent relapse to alcohol, i.e., you're supposed to have stopped drinking by the time you start these medications. So that's not helpful for someone that's actively drinking and is trying to reduce or cut back. Um, Again, can use these things off license, but that's what they're licensed for. So we don't really have a good drug treatment for someone who's actively drinking, certainly not someone with liver disease. Although if they don't have liver disease, then yeah, disulfiram is an option. Disulfiram certainly, has been associated with acute liver failure, but that is, also in people who didn't have pre-existing liver disease that they developed acute liver failure with disulfiram. And so I think the general consensus in the hepatology community is that it's a kind of red light for disulfiram. But I like the way you phrase it, which is that continuing to drink is also seriously risky. And you're right. It's like, well, it's doing nothing safer than trying this drug, which may have an idiosyncratic reaction that we can't predict anyway.
Mm.
Uh, so no, I think that's a great question, and as I say, gets into the kind of ethical areas that and areas of balance of risk that I'm interested in. I mean, the other one that springs to mind is a sort of related question is about liver transplantation and alcohol relapse risk,
Yeah.
because there's a growing feeling among hepatologists, some hepatologists, certainly in countries where liver organ scarcity is not such a big issue as it is here, that we should be transplanting more people with alcohol use disorder. And even if they have relapsed before, even if they are seen to have a very high risk of relapse after transplant, that you could still transplant them and then, try to treat that post transplant, try to manage it, because, the transplant is designed to extend their life and improve their quality of life, and they'll die without it. So, you know, is there a case there that if we had enough organs, we could give people liver transplants and then just try to manage the alcohol relapse risk afterwards?
Mm.
Uh,
Yeah. Great. Okay, thank you. Things are hotting up on the questions, but it's Alistair's shot now. Alistair, please, you probably want to talk about yours. You can do that yourself if you possible. You unmute yourself.
Sure. Thanks. Happy to do that, Aisha. A couple of comments and a couple of quick questions. Firstly, that's fantastic, Chris. Just great to see, and great to see liver clinicians of various shapes and hues participating in a SARN alcohol occasional. Very, very encouraging. Second comment before we get to the questions is I think that's a fantastic idea about your opt-out. How are we going to manage your relapse prevention rather than whether we're going to manage it or not? I mean, that's just absolutely spot on. Two questions, really. You made the point that people often, I suppose this, if you were doing your opt-out, this wouldn't be relevant, but people often, as you say they don't need help or don't want help. And I think that's partly a chicken and egg because the alcohol nurses in the hospital, the alcohol care teams or whatever, are very stretched. So if they go and speak to the patient and the patient says, no, I don't need help, great, they can move on to the next person.
yeah.
So, so one way I think that I think there's a greatly underutilized resource, which I was as guilty of not using as everybody else. But you know, patients, experts by experience, patients with lived experience, I think we should be getting them into the hospital, into the wards to chat to patients. They're the ones who can say, "Listen, mate, you think you can stop drinking, but I tell you, you can't without help." And
Yeah.
it's often that conversation which is more precipitates change. So I'm interested in what you think about that.
Mm.
And my second question is that I was kind of puzzled as to why the ranking, the prioritization was different for community practitioners than for the other groups. I mean, I'd like to know a bit more about that.
Yeah. Right. So on the peers point of things, yeah, I think definitely is a role for peers, and certainly like the patient group that I have with lived experience all are very keen that their experience, that people could learn from their experience, that they'd be happy to come and talk to people, and there is definitely a cohort of people who are like that. On the other hand, lots of people I speak to in the clinic, when I say to them, I think you should go to this group, or I think you should talk to this person, they say, I don't want to talk to them. I'm not like them. And there's that othering thing still goes on.
Mhm.
And so it's like if you could get a kind of a near peer, so someone who's like kind of similar to that person, if your person with liver disease was the kind of person that had 6 pints in the pub every night with the lads, or after a round of golf, and you can find that one of his golfing buddies to come and talk to him, then that might work. But if that person's also, let's say deeply kind of atheist, and the person you send to them is a sort of evangelical, reformed alcoholic, then you do risk putting them off. So I don't know how you would match people, but I think that would have to be part of it. But I think you're right. It definitely is worth trying, and certainly when I speak to the patient group, they often say that there are things you would tell a peer that you're not going to tell your doctor. And it's an obvious criticism of these interviews is that it was me that did them, I think there's definitely a role for that. And your second question was about the community practitioners. So I closed my. I'm sort of writing up this part about it in the thesis at the moment. I had it open, but off the top of my head, one of the things the community practitioners put as the number one priority was a multidisciplinary clinic run by the hospital. So I don't know whether they're trying to offload or like, think that we should. It's like they think we should take more responsibility, and we think they should take more responsibility. There might be a bit of that going on. But yeah, sorry, I need to have a little bit more look at what the community petitioners ranked highly. I'll try to do that as we're chatting, and maybe can get back to you.
Brilliant, thank you. And just that was the same point I wanted to make on that ranking. That really jumped out at me, their ranking, and how it was more aligned to, I can't remember what was on the other line there with it, but anyway,
Yeah, the last two columns is kind of hard to interpret because we only got one or two people in there.
yeah,
But
yeah. Okay, we've got so many comments, questions. I'm going to try and just read it out. Denise says our services advocate zero alcohol, especially in liver cirrhosis. Ashwin, I don't know, Ashwin, if you want to read out your question around the evidence base around
Yeah,
alcohol
sure.
relapse. Great, thank you.
Hi, Chris.
Hi.
Thanks for that talk. Excellent work that you're doing. Great to have such wide engagement in this project. So I really wanted to hear your thoughts about, I think the opt-out idea is fantastic. What about the practicality of delivering that within the hepatology workforce? How would you also integrate psychosocial treatments into that with people who haven't got experience of treating alcohol use disorder?
Yeah. Well, I think you've got to have a sort of multi-pronged strategy there. As you allude to, these medications are not, are not a kind of golden ticket or a golden pill. And I think some of our colleagues in hepatology, and certainly maybe me going into this, thought that they could be or might be. They do have to work with other sort of forms of relapse prevention and with patient engagement about their triggers and their cravings and problems of alcohol and so on, all of that other relapse prevention work. And actually, one of the recommendations that got bounced was that we should be able to prescribe these drugs without people engaging in any other type of relapse prevention. That suggestion to kind of open up the prescribing of these things got bounced. So I think, well, there should be more training for us. So you could design a probably quite short training program that would, empower and educate hepatologists, both in terms of prescribing, but also a bit of relapse prevention, motivational interviewing, whatever you want to call it. So upskilling the hepatology workforce. I do think that we need to involve experts, psychologists, community practitioners, etc., who are used to doing this and get them into the clinics. And if we're going to do that, then it has to be funded. And one of the ways, and it'll be funded if it's effective. Like if you can link it to outcomes like hospitalization, mortality, and so on, then it'll get funded. And as I'm sure the evidence out there for these multidisciplinary clinics is very much, before and after, which isn't going to convince too many people, I don't think. It's like, well, we did this clinic, and then the people they had a lot of admissions before they came to the clinic, and then afterwards they had less. So, well, how do you know that they didn't just have less admissions because they got better on their own or they were sicker or whatever? So, I'm bouncing around in my head how we could do like a clinical trial or a feasibility study of our MDT clinic. How you would sort of show the cost effectiveness of that, so that you can do it in a way where it can be properly funded. But I mean, some of the stuff, like we have a relapse prevention book that we give to all of our transplant candidates. The alcohol care team have something similar that they can give to people. I mean, even if it was as simple as, everybody, we want you to complete this book, like as homework or whatever, and then it's not that labor intensive for us to go through a process like that. I think there are solutions that are not so intensive. I mean, when we think about psychotherapy or psychological or psychosocial interventions, really we should be talking about very kind of evidence-based and theoretically grounded things like CBT or MET or whatever. But in reality, that's not what happens in community alcohol services. People get a bit of this and a bit of that, and whatever kind of people are trained to deliver. So that's another sort of skill to overcome.
Brilliant. Thank you. Hopefully that has answered your question, Ashwin. Thank you so much for that. We have a couple of comments again in the text. Thanks, Richard, around alcohol-free drinks do have their place and he doesn't dismiss them. Agree totally. Read the taste and variety. We've got an interest and anything that might prevent death is worth considering. So thanks, Richard, for that. Great reflections. We have one. I don't know the name of the person from the email or the address here. I have seen alcohol-dependent child PUA do well with the sulfur implants in Poland. Any thoughts on this as a trial?
I've also seen that,
Ah,
and I've seen naltrexone implants as well, which is a great idea, isn't it? I mean, it's like you get the implant for 3 months. You don't have to worry about taking the drug or anything. So yeah, I've seen that work. It'd be a really interesting clinical trial to do or to get ethics for. But I don't suggest recommending it or doing it off prescription or off license at the moment. Um, Apparently, there's also a great hypnotist for any of your Lithuanian patients. The Lithuanians talk about this guy, great hypnotist. I'll be happy to send the link for him later.
thanks.
Yeah,
I mean, we have
Poland's where you go for your implants. Yeah, they were. I think there was a clinic in London doing them as well.
We've got so many questions, and I think what we're going to have to do is probably we can take them to the side and then can put them to you and somehow share them because there's some really interesting stuff coming through. I'm just giving a shout out because I'm a nurse and Jen is a nurse saying that thank you for the enlightenment about the zero and low alcohol free. Thanks to everyone's comments, really helpful. I worked as a hepatology nurse specialist. And I think this might be our last, if not sort of second last question, Leanne. McPherson. Leanne, I don't know if you want to ask this question about the incidence of ARBD within the clinic. If
Aye,
not,
I
yes,
think I've
great.
unmuted myself. Yeah, just when you were talking about the relapse prevention rate, so that was what piqued my interest in the webinar this afternoon because I've got an ARBD nurse-led clinic, um, and relapse rates are really quite high within my client group for obvious reasons because their executive functions impaired. So I was wondering what the incidence of a diagnosed ARBD within the hepatology clinic was.
Short answer, I don't know. But it'd be something that we could audit. So it'd be an interesting audit.
Yeah, yeah.
But
And I
short
think
answer, I don't
because
know. I
yeah,
guess I'd be more worried about what the incidence is in the people at DNA in my clinic, because it's probably likely to be higher there.
yeah, and certainly that Christopher, that's my experience. So I get loads of patients that don't attend, but we never discharge them because we know they might have forgotten, they might have returned to drinking at that point, but we'll leave the door open for that reason. Just out of interest, so part of the criteria for patients coming to see me and the consultant psychiatrist is a Wernicke's or if they've been diagnosed with a hepatic encephalopathy as well, because we would class that as an ARBD, albeit they've recovered, but we know it does impact in their cognition. And we try and offer education round about that and that cumulative damage to the brain with the continued drinking. So it would be interesting.
Yeah, I think this is the thing about these patients. There's so much going on, and it does make them complex and difficult. And yeah, when somebody turns up to clinic, it doesn't turn up to clinic. There's a lot of the danger of just saying, oh well, it's that usual sort of person. They're not bothered coming. Blah blah blah. And unfortunately, as you say, we have to try and be a bit more sympathetic than that, and be assertive and positive about trying to reach out to these people and engage them.
Yeah.
For what it's worth, when we looked at our clinic attendance, the people that came to clinic within the year after admission, we had abstinence rates of about 80% in that group. But then when we looked at people that had 2 DNAs or more, the abstinence rate in that group was like 20%, 30%. So
Yeah.
I'm
And
not
I
saying
think
that just coming to our clinic does anything, but it's a marker of them being engaged and having support and sort of all of those kind of things coming together.
Absolutely. And I think, I mean, certainly for what we find within the AIBD clinic, we're completely unfunded. So we were initially started as a test of change, but we've built up, we've got 130 people sitting in a caseload that's not funded. So we've been asked no to shut it down because where do these people go? And certainly there's been really good outcomes. I'm not saying there's not been relapse, because there absolutely has, but it's been less. We've reduced hospital admissions, we've reduced the stays, because if they're open to me, I'm able to kind of intervene and try and get them discharged quicker.
Yeah.
But it's just trying to evidence that it's working in the hope that you get that funding, isn't it?
And this is it. But I think one thing I'd like to come out of this thesis, if possible, is like, how do you get, and hepatology, I think, are really bad for this, or seem to be, where like we're great at doing stuff. We seem to be quite good at doing stuff, starting stuff, getting stuff done. We start these new clinics, or we do this new intervention, whatever, and then we kind of evaluate, is it working or not, right? But if you look at other areas which have got a lot more money and a lot more evidence base, it is still the sort of randomized trial that is king. And maybe that's not possible in these patients, but we do need to, like your clinic, we need to leverage the data from that clinic in a way that's going to be meaningful to funders, so that it can be replicated and rolled out, and instead of it being, sporadic and supported by enthusiastic people such as ourselves.
And I'm gonna stop you there. Sorry, Christopher, because we are run out of time. There has been so much conversation in the chat. We'll try and pull that together. I was trying to summarize, but there's so many, so we will have to come back to it. Maybe there's a part two to this whole piece of work. It's just really to say thank you so much for such a stimulating conversation. I mean, there's so much more to say about this. Thank you, everyone, for joining us. Quick shout out, our next seminar is the 1st of September, and it's looking at Scotland's first managed alcohol programme that will be of interest to many of you, evaluating the impact to inform future service delivery and research, from colleagues from the University of Stirling. And a big shout out, this is Cancer Prevention Action Week, if you don't already know it, and SHAP has produced a updated publication, 2025 Alcohol and Cancer Risks, a guide for health professionals. Links in the chat. Please check it out, use it, share it. And thank you again so much, Christopher. We will get some of these questions to you and see if we can send something back. But thank you so much. It was a fantastic session, brilliant research. I'm really interested in it. It's great when you see this work and you think, okay, there's really lots of stuff in here that is going to hopefully change practice and get the rest of us motivated. So hopefully you have left everybody feeling highly motivated. This is really important work we do in the field as alcohol researchers, clinicians, people with lived experience. We all have a role to play. So
Yeah.
thank you so much for joining us today. Christopher, last word over to you, and we will say goodbye.
Yeah, well, thank you so much for the platform, and for all the people who on this call who have already supported me. And yeah, don't worry if you're interested. I'm happy to come calling again for more help and more collaboration. So.
Brilliant, brilliant. Thank you so much. Well done, everyone. Have a lovely day and keep up the good work. Let's not give up. It's really important work, as I say, and we absolutely see the differences that can be made in people's lives. Thank you again, everyone. We had over 80 people join the call today. People are now leaving. Thanks for your time, and also to you, Christopher, for the questions. Really great discussion on the chat. Take care, everyone. Thank you so
Thank
much.
you.
Bye.